All right, let's dive in. Today, we're taking a close, scholarly look at two really key prophylactic strategies you see in the intensive care unit. Selective decontamination of the digestive tract, which we'll call STD, and selective oropharyngeal decontamination, or SOD. We're going to break down the evidence and get into the nitty-gritty of the debate surrounding how we prevent ICU-acquired infections.
So here's our roadmap. First, we'll set the stage and look at the clinical problem we're trying to solve. Then, we'll get into the why behind these protocols, how they're actually administered, and then really dissect the evidence for their efficacy. We'll bring it all together with a cohort analysis and then wrap up by tackling the big questions around complications, especially the risk of antibiotic resistance.
Okay, so what's the core issue here? Well, it all starts with a fundamental challenge in the ICU. When a patient is critically ill, they're at an incredibly high risk of picking up a new infection during their stay. And these aren't just minor bumps in the road. These nosocomial infections are a massive driver of illness, death, and of course, healthcare costs.
Now here's the crucial part. Where do these infections come from? You might think it's all from the hospital environment, but often the source is the patient's own body. Under the immense stress of critical illness, the normally harmless bacteria that live in our gut and throat, our commensal flora, can turn into dangerous pathogens. Or this native flora gets pushed out by more aggressive, drug-resistant bacteria, particularly those nasty gram-negative bugs that love to cause respiratory infections. This right here is the central problem that decontamination is trying to solve.
And that brings us to the why behind it all. The core idea is simple but powerful. Instead of waiting for a full-blown infection to take hold and then scrambling to treat it, why not get ahead of the problem? The goal is to be proactive to prevent these infections before they even have a chance to start, by selectively knocking out the potential bad guys. This is done using two main protocols. First, you have SDD. Think of this as the comprehensive, all-in approach. It uses topical, non-absorbable antibiotics to decontaminate the entire digestive tract, from mouth to anus, and it's backed up by a short, 4-day course of systemic IV antibiotics. Then you have SOD, which is much more targeted. It uses just a topical antibiotic paste to decontaminate the throat, the oropharynx, and it usually skips that systemic IV component.
I love this analogy because it really captures the principle perfectly. The point isn't to sterilize the patient. That would actually be harmful to their healthy microbiome. No, the idea is to act like a careful gardener. You selectively remove the potentially harmful bacteria and yeasts, those are your weeds, which then allows the patient's own beneficial anaerobic flora, the roses, to hold their ground and thrive. It's a really elegant ecological way to think about preventing infection.
So, that's the theory. How does this actually play out in a busy ICU? Let's get practical and look at who gets this treatment and what it actually involves day to day.
First, you have to identify the right patient. We're talking about high-risk individuals, typically those who are expected to be on a ventilator for more than 48 hours or in the ICU for more than 72 hours. Once identified, they get the topical agents, an oral paste, and for STD, a suspension for the gut, usually containing things like tobramycin, colistin, and amphotericin B. If it's SDD, you add that 4-day course of an IV cephalosporin. And because these are potent drugs, you absolutely have to monitor drug levels, especially for aminoglycosides, in patients who are also on hemofiltration.
The theory is elegant. The protocol is clear. But the million-dollar question is, does it actually work? Now we get to the fun part, the data. And let me tell you, these strategies have been studied rigorously, and the results are pretty compelling.
Let's start with the big one, mortality. An early, really seminal trial on classic STD found a 35% relative risk reduction. Just let that sink in. Now, more recent, huge studies have dialed that back to a more modest, but still incredibly significant 11 to 13% reduction for both protocols. But the bottom line is, a survival benefit is a consistent finding across the board.
The impact on specific infections is just as striking. Let's take ventilator-associated pneumonia, or VAP, a dreaded complication in the ICU. In control groups, you might see an incidence rate as high as 23%. With SOD, that plummets to just over 10%. You're cutting the rate by more than half. And SDD shows similarly impressive reductions.
And check this out. When we look at bloodstream infections caused by those gram-negative bacteria from the gut,
the effective SDD is staggering, an 81% reduction. For comparison, the more targeted SOD protocol still gets you a respectable 30% reduction. So the takeaway here is clear. Both work, but the full gut decontamination of SDD has a much more profound effect on stopping bacteria from escaping the gut into the bloodstream.
Okay, percentages are powerful, but sometimes it's hard to grasp what they really mean for patients. So let's try a thought experiment. Let's create a hypothetical cohort of 1,000 ICU patients and see what the impact looks like at a population level.
So, in our cohort of 1,000 patients, if we do nothing, we can expect about 230 cases of VAP. That's a huge burden. Now, let's implement the SOD protocol. Boom, the number of cases drops to around 103. You've just prevented VAP in over 120 people. Think about the mortality benefit. You're potentially saving dozens of lives in this group alone. And here's the really counterintuitive part. You actually end up using about 10% fewer total IV antibiotics, simply because you're preventing all those downstream infections that would have needed heavy-duty treatment.
Of course, in medicine, there's no such thing as a free lunch. We've seen the powerful benefits, but we absolutely have to talk about the other side of the coin. The risks, the costs, and the elephant in the room, antimicrobial resistance.
And this, right here, is the central hang-up for many clinicians. It's the big question. If we start using antibiotics prophylactically on a massive scale, are we just breeding the next generation of superbugs? It's the most significant and, frankly, the most valid objection to rolling these strategies out everywhere.
There's this great metaphor that really gets at this ecological concern. When you drain the swamp, you might find a new kind of mosquito. It's a powerful warning. By suppressing one set of problem bacteria, are we just clearing the way for a new, maybe even tougher, resistant organism to take its place?
But you know, when you look at the data, the story on resistance is way more nuanced than you might think. We already saw that overall therapeutic antibiotic use actually goes down. Sure, with SDD you're using more cephalosporins up front, but you're using fewer of other potent antibiotics down the line. And here's the kicker. Large-scale studies have consistently shown a reduced prevalence of resistant gram-negative bacteria in ICUs that use these protocols. Now, are there some warning signs? Yes. We see some signals of emerging resistance genes in the gut flora, and that demands constant vigilance. But the doomsday scenario of runaway resistance just hasn't happened.
So this brings us to the practical choice between the two. You can think of SDD as the Rolls-Royce option. It gives you the biggest bang for your buck in terms of infection reduction and likely a bigger survival advantage. SOD is more like the reliable sedan. It's still incredibly effective, but it's simpler to do and often looks better from a cost-effectiveness standpoint. Which one you choose really depends on your local situation, your patient mix, your baseline infection rates, and your existing resistance problems.
And let's just pause on this point for a second because it's critical. In the entire field of preventative critical care, these strategies are in a league of their own. As of right now, there is no other intervention, not a hygiene protocol, not a new device, not another drug that has been shown to have this kind of effect on saving lives in ventilated ICU patients. Period.
So we end here with a provocative thought. The evidence for saving lives and cutting down infections is incredibly robust. It's compelling. The risks, especially around resistance, are real, but they seem to be manageable and maybe not as scary as we once thought. This leaves us with a fundamental clinical and ethical question. Given everything we now know, what's the bigger risk? Is it using these life-saving strategies, or is it failing to?